you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
This bout intussusception. Check it, cause we microphone check in. It's a serious disease that simply can't be. There's one way to diagnose, that's ultrasound for show. Check out what I say, scan in a systematic way. It goes up, it goes down, the large bowel, and hey, don't be scared. Besides, ultrasound is rare, pretty sensitive and specific. Oh yeah, this here is best like blam.
There's one set of patients we've neglected here on the podcast is probably little adults. No, I mean the smallest of small adults, also known by some as children. And if there's an organ system that we've ignored here on the podcast, it's probably the bowel. We don't talk that much about bowel ultrasound considering how much it gives us problems. So we're going to remedy that for you. Today, we've got an expert in intussusception here with us, Dr. Russ Horowitz. Now, we met Russ through our good friend John Bayless, the ultrasound director of Cook County, an all-around awesome dude. He told us Russ knew what he was talking about, so we know Russ knows what he's talking about. Now, I also got my homeboy Andy Slosh from the PMED podcast to chime in, because if there's one person who I go to when I have a little adult ultrasound question, it's Andy. In fact, that's why Andy is our Ultrasound Leadership Academy Little Adult Ultrasound Professor Emeritus. He's done millions, if not billions, of these scans, and there's no one in the world I'd rather have taken care of one of my children if they get really sick. So we'll get his take on this as well. But let's not belabor the point any longer. Here it is, intussusception.
All right, guys, Mike and Matt here with the Ultrasound Podcast. We have with us Russ Horowitz, the man from Chicago, who is here today with his good friend Elvis Presley to talk to us about how to ultrasound little adults.
So Russ, what exactly do you do? Where do you work right now?
I'm a peds doc at Ann and Robert H. Lurie Children's Hospital in Chicago.
I got to be honest with you. As scared as I am to argue with someone who has a lamp of Elvis Presley in their office, I'm going to just throw it out there. Where I work, I place an order for this, and it's about 20 minutes before a tech arrives, whisks the patient away, and then I'm seeing 3 or 4 other kids who may or may not be sick. They're doing the scan with the machine that's better than mine, sending it to someone who's trained for years on how to read this and seen hundreds of these, and then they send me the result, their expert analysis. So tell me why I should do this myself.
Well, I got a couple answers. The first is, I'm sure there's a lot of people out there who are sort of saying, where do you work and you can get an ultrasound in 20 minutes? Anybody else out there got one of those circumstances?
Bueller.
Bueller. Most importantly, this is really going to affect kind of your decision making. When you have this chief complaint recorded on your chart, you wheel your ultrasound machine in. At that bedside, you'll be able to diagnose the intussusception. And then based upon that, instead of spending your time placing the order for the other process to happen, you can start arranging for this child's disposition. If it's your hospital, you already have your diagnosis, and then you're done. But a lot of people don't have that ability, so they're going to have to start coming up with this diagnosis, and they might be the best sonographer in-house. And if you don't have a pediatric sonographer 24 hours a day, 7 days a week, you may very well be the best person who's seen it the most to come up with this diagnosis, and then you'll have to use that information to arrange for that child to get transferred. You'll then know sort of deep in your soul you're doing it for the right reason, that it really has the disease to justify him going in the ambulance, getting transferred some distance away.
So I guess I was thinking of this as I go see a kid and I think they may have intussusception, then I come back out, and then it's a decision point for me as to whether or not to click the order or go get the ultrasound machine, take it in and do it. But you're saying, I mean, you just see it on the chart, abdominal pain, possible intussusception. You're taking the machine in with you while you're examining the patient, you're scanning their belly, and it's not really adding much time at all.
Yeah, you could think about it sort of analogously to 40-year-old with right upper quadrant abdominal pain. You're going to bring your ultrasound machine in straight away because high in your differential is going to be gallstones. If you have a 2-year-old with intermittent colicky abdominal pain, high in your differential is intussusception. Might as well bring your machine in straight away.
That makes sense. And I mean, my residents here, I was being a little facetious with that question. We definitely try to train them on this because they're going to be working in those community places that you mentioned where some of the community places I've worked at, our pediatric sonographers are incredible here at UK, but just 15 minutes away at outside facilities I've worked, and they won't even scan a kid. They say, no, we don't do that. We're not comfortable with that. So it is a really important skill to learn. Can you give me an example of when it's really mattered for you?
Yeah, I had one just a couple of weeks ago, and after working at a tertiary care children's hospital, you start to feel like you're pretty used to what the common complaints are and how likely certain things are going to be. But I had a child that was about 3 or 4 in the morning, and she was 2 years old, and she had vomiting, diarrhea, and severe for about 4 days. So the likelihood for her to have intussusception is pretty low. It's probably going to be gastroenteritis. But one of my residents said to me, could this be intussusception? And I didn't feel strong enough to justify calling the sonographer in at that time, but since it's such an easy exam, it's a worthwhile investigation. And I checked and I saw that she did have a giant intussusception. And for someone like this, I could have easily have blown it off as gastroenteritis and sent her home. She tolerated PO, but I was really glad that I looked, and I kind of would have felt a little embarrassed to call the sonographer in if my index of suspicion was so low. But then I don't really have to explain it to anybody else if I'm just doing the test. And now we had a positive. I was really glad that I looked and I didn't send her home because for sure she was coming back with that intussusception.
That's a great point, Russ. Sometimes it's not about just clicking a button. Sometimes you actually have to convince the tech to come in or convince the radiologist that they need to call someone in from home who's asleep. I mean, at my place, I can't even get a tech in the middle of the night. Our radiology residents do all the scans. And, I'll be damned if I want them doing a complicated scan that they've done 5 times before and me taking that as the definite truth as to whether the patient has the diagnosis or not. You said something interesting though, and you mentioned that you'd be comfortable calling intussusception if you saw it on your ultrasound. But what about ruling it out? Would you be comfortable ruling it out in that setting?
So that's a great question. I think it's a lot like how many ultrasonographers sort of start. At first, the diagnosis is the diagnosis if you find it, but the rule out, the sensitivity isn't as good. The more you do, the more comfortable you become. And as long as you kind of know that you've investigated thoroughly, then that's going to kind of give you the idea about whether this person has it or not. It depends a little bit about what your index of suspicion is. So if I was really sure, but I didn't see it, but there might have been something a little funny, then that's when I'm going to go to the ultrasound experts, maybe the sonographer who will spend a lot more time, or the radiologist will look more closely. But if I see what I'm looking for and it's totally negative, then I can move on and start investigating the child for other diagnoses.
It reminds me a lot of appendicitis, where we kind of say, your pretest probability is extremely important as to whether you want to continue on with additional investigations after a non-diagnostic scan, because we're not really getting negative scans in these cases, right? We're getting non-diagnostic scans. So you only have a definite endpoint when it's positive, right? So it kind of plays for me almost the same way that we treat appendicitis with ultrasound.
It kind of agitates me when I hear people say, is it sensitive enough to rule this disease out? When really what they should be asking is it sensitive enough, is the negative likelihood ratio such that you can rule out in this patient? If you have really low pretest probability patients, you may be able to accept a not quite a strong negative likelihood ratio or not quite as good a sensitivity if you're a doctor and you use it like a physician should, like you're talking about.
Yeah. I mean, there's a couple of other things that you can find when you're looking for that. So if you see a really inflated bowel with a lot of fluid in there and the story is pretty consistent with gastroenteritis, I feel even more comfortable making that diagnosis. So from that sense, I'm both ruling out the intussusception disease and then helping to rule in another disease by my ultrasound findings.
One thing you didn't address is how many you really need to do of these to get comfortable. How hard of a test do you think this is? How many times do you think someone would have to do this to start feeling comfortable enough to trust their judgment?
That's a good question. I think every ultrasound application is going to have some sort of learning curve. I put this at a lot easier than gallstones, a lot easier than cardiac. I would say, if you saw half a dozen true positives and half a dozen negatives, you'd feel really good because there's not that very much variability in what intussusception looks like from one person to another.
That's awesome. That's up in there in like 10-minute DVT education land. That's pretty sweet.
I put it at DVT level, honestly, because DVT, if you compress, if you can identify the vessel, the person's not gigantic and you know where to go, and you can compress those vessels, you're going to say that it's going to be a negative study. And intussusception, if you can identify your landmarks and see the entire ileocecal area and large bowel, then you found what you're looking for.
That's a good question. Now, how often do you run into situations like you might see in Kentucky and South Carolina where you can't actually visualize the bowel due to the layer of tissue on these children?
Well, remember, thankfully the kids aren't so big, because this is disease of kids somewhere between 5 months to 3 years of age. Even the biggest kids, you're probably only going down a couple of centimeters. So I don't have that problem. The biggest problem would be overlying bowel gas. And you made the analogy of appendicitis. If you can sort of milk out some of that bowel and make sure that you're looking in the right spot, you can see some peristalsis, some fluid within the bowel, then you're going to be able to say you've seen that area that's concerning to you.
Russ, is there anything else in the video that you sent us that wasn't really covered you think is an important tip, or anything else you want to bring up?
I think one of the things is you want the child to be as comfortable as possible, because cooperation is really going to be key. So I like to have the gel warmed either in a gel warmer, which is about $100, or you can put it in the blanket warmer outside the trauma room. And you may choose to have the child sort of lay back onto the parent so they'll be as comfortable as possible. Start in a really organized fashion in the right lower quadrant and follow that all the way up and around, paying particular attention to the right upper quadrant, because that's really where most intussusceptions are going to be found.
All right, well, Elvis is starting to creep me out, so I think we probably should get on to the video.
Thanks, Russ.
Take care, guys.
Yeah, I know. We're supposed to be talking about intussusception today, but we want to tell you really quickly about a project we've been working on for about 9 months now, and we're ready to unleash. Here it is. You know we love putting on courses. CastleFest, Alaska Fest, these are phenomenal experiences, but they're a lot of work.
And we know that not everyone can come to these types of big conferences, and we certainly can't travel everywhere to put them on.
As much as we'd love to come to you and put these conferences on, it's just not feasible to do more than a few a year.
And we don't need to. We know you have mad skills and you can put on your own courses. It actually is a ton of work, though, to organize and put on a course, and we understand you're busy. So even though we know you can do it, you may just need a little help doing it.
So we're going to give you that help. We'd like to introduce Course in a Box.
We've put together the total package and done all the heavy lifting so you can focus on the actual day. Say you're a residency and you want to put on a 1 to 2 day course, but it's just you.
We'll send you all the lectures ready to go, straight from the Ultrasound Leadership Academy. Your participants can watch ahead of time, or you can even play them the day of when everyone is together. We recommend they watch ahead of time, so then you can focus on hands-on when you're together in the same room.
If you do watch them ahead of time, then we'll also send you a super short summary presentation to give the day of and make sure everyone got the main points. And we'll send you a quiz to give them and make sure they watched it so you can hold them accountable.
You can make them pass the quiz before they move on to hands-on, or rewatch the videos if they don't pass. No slackers.
Then for the hands-on part, we'll send you specific SDOTs, or Standard Direct Observed Tests, with checkoffs to make sure each participant is getting it. No one finishes the hands-on or moves on to the next station until they've completed specific skills. It's accountability, homies.
We'll also give you a checklist to go through the day before and make sure you've got all the things that you need ahead of time. Don't make the same mistakes we've made running courses.
So no need to waste 20 hours preparing lectures or waste precious hands-on time the day of when they could be scanning. We've got your back.
Honestly, I wish this was available when I was just starting out. It's super valuable to have all this in one place. So Malin, tell them how much this super valuable toolkit costs.
Well, it says here $0. Free? Seriously?
Whoa, who approved that?
Not me, but I guess since we've said it, we should honor it.
Fine, but I'm not happy about it. This FOAMed thing's getting a little out of hand. And for what? So residents can learn this skill and potentially save lives? Give me a break.
But wait, there's more.
You know us, we can't leave well enough alone, so if you want to put on something bigger and even better, we've got some other stuff to offer.
One of the toughest, most time-consuming, and expensive parts of putting on a course like CastleFest, or even a smaller course, is the CME.
The reams of paperwork are maddening, and the costs are ridiculous.
For CastleFest alone, it cost us over $10,000 to record and get online CME credit for it. So we're going to do all that work for you as well.
If you want to put on a full-fledged CME course locally, then we'll make sure and send you all the material and lectures with the CME credit attached, so no paperwork.
Seriously, zero paperwork. Trust us, the paperwork involved, not to mention the costs, can give you nightmares. So let us handle it. Obviously, we have to pay for the CME and pay someone to do the paperwork, so that part's not free.
Another huge hurdle you have is gathering up enough machines. So we solve that for you as well. You tell us how many people are coming in advance, and we make sure that you have all the machines there.
Another problem, administration. You can do this by yourself with all these tools, but if you really want someone on site, then we'll send you that as well. We'll send you one of our experienced administrators who run CastleFest and other conferences.
The last thing that we can offer to help is ourselves. We can be there for you, and virtually, of course.
We can Google Hangout with your group after your summary slides to answer questions they may have.
Or if you really want to push the limits, we could help with hands-on stations via Google Glass.
Recently, we did a study at Kentucky where we put Google Glass on a med student who had never done a cardiac ultrasound before. We remotely walked them through how to get a perfect parasternal long-axis view good enough to measure EPSS. We randomized the clips and sent them to an expert to rate, and we found that 100% of the students were able to do it in less than 3 minutes, while only 17% of the control group without glass were able to do it. Pretty amazing results.
So we've proven that someone remotely via Glass can actually teach you how to get proper views. So if you want to go all out, we'll send you all the material electronically, but we'll also send you an actual package that will include 2 pairs of Google Glasses and the iPads with the S-dots loaded on them, so you can track electronically the student's success.
This still will take some time for you, and the CME, glass, and advanced stuff costs us and will cost you. So we're happy to help you get the word out. We'll create a place on the podcast where you can announce your upcoming course. Obviously, you'll charge your participants to cover the cost of CME, your time, and the expenses, and that's fine. Charge whatever you need to.
And remember, if you're doing it for free for residents, medical students, or just colleagues who want to learn, you can still take advantage of the free course in a box. The other stuff is just available if you want it.
And Ultrasound Leadership Academy fellows, all of this, including the CME part, is included in the Academy. We actually created this as a response to an issue a few of you brought up about wanting to do courses where you are locally in Norway and Australia, but needing a little help doing it.
Lastly, we've got limited glass and limited administrators. So if you want this, go to the ultrasoundpodcast.com and go to the course in a box section. Apply and tell us what you want, and we'll send you a quote.
Or if you just want the free stuff, just let us know and we'll send it your way.
Viva la ultrasound!
I'm not saying that Viva Ultrasound shit.
It's a course in a box.
Hi, my name is Russ Horowitz, and I'm the Director of Emergency and Critical Care Ultrasound at Ann and Robert H. Lurie Children's Hospital of Chicago.
Wow, that is one handsome kid.
When I think about imaging for intussusception, a number of reasons and sort of benefits come to mind. Now, a child comes in with crampy, intermittent abdominal pain, some vomiting, and I have a bunch of diagnoses that pop into my head. Using the bedside ultrasound, I can really narrow that differential, and I can really reduce any unnecessary testing, particularly those that are going to involve radiation like X-ray and CAT scan, to speed the diagnosis. But most importantly, I think has to do with transfer and disposition of my patient. Now, working at a tertiary care children's hospital, I have the benefit of sonographers who can make the diagnosis and radiologists who are comfortable doing the reduction. But at a lot of other facilities, neither one of those exists, and you're the most capable sonographer in hospital. If your radiologist can't do the reduction, you're faced with transferring this child to another facility that can do that reduction. And without a good image, you may simply be left with simply the suspicion that the child has intussusception, but you don't know for sure. But if you're the person who can make that diagnosis, you can say for sure the child has it, and you know deep in your soul you're transferring that child for the best possible reason. The question arises, though, can emergency physicians make this diagnosis right at the bedside? And the answer is really yes, that we've seen a number of case studies showing that emergency physicians can make this diagnosis, do a wonderful job. This nice study published in Annals of Emergency Medicine 2012 showed that pediatric emergency medicine physicians are really good at it with a high degree of sensitivity and specificity. So in this particular study, they used 6 pediatric emergency medicine physicians who've had some experience in ultrasound, but had not experience at all using ultrasound to evaluate the bowel. They did a 1-hour focused training session for them and then said image those patients with suspicion of intussusception. You can see when they said that someone had it, they really had it for sure. So how do we go about this? Well, when I'm going to image a child, I prefer to have a kid like this than one like this who I'm performing the sonography on. One way to minimize this is to gain a lot of comfort from the child, have the child perhaps laying right onto the parent. At the bed, lay everybody nice and flat. And one of the big complaints about ultrasound is that the gel's real cold and uncomfortable. And if you're trying to get some really good images, we want to minimize this entirely. So you can pick up this gel warmer for about $100. If you don't have one of these, you can put your gel right into the towel warmer right outside the trauma bay. Keep that in there and run for it when you need it. If that's not availability, you can just put it right on the neonatal resuscitation bed in your trauma room. The way that I start is I start in the transverse plane using either curvilinear, which is pictured here, or a high-frequency linear probe right at the level of the bladder, nice and easy to identify. Then I move laterally to identify the iliac vessels. That tells me the level at which I'm going to start to investigate. Continue to move laterally until I see a bright hyperechoic oblique line coming from the top left of the screen. And that's going to be the iliac crest, and right above that will be the psoas muscle. Drag my probe up toward the head along the ascending colon. Then once I identify liver, right across the transverse colon. When I see spleen, rotate the probe back down, go down the descending colon. And that gives me a full survey of where I'd identify an ileocolic or a colic intussusception. So let's take a picture at what normal bowel looks like, and there's going to be 5 things that you'd see in normal bowel: air, water, poop, peristalsis, and normal bowel. So we'll let this move run. We'll identify each of those structures as we go through here and stop periodically. So here we can see a survey of normal bowel. As we go through back again, I'll identify what those structures are going to look like. So the first here is air. Air will appear as hyperechoic dots or reverberating lines, like when you look for pneumothorax and you evaluate the lung. Water will be anechoic, contained within bowel. Poop will be sort of hypoechoic, little clumps like this that usually don't shadow. We'll be able to identify the peristalsis as the bowel sort of twists and tumbles, and you'll see the hyperechoic dots as they toss across the screen. And then the bowel wall sometimes is identifiable. We'll see it as that comes into view here, as that shifts and moves with the peristalsis. Now we're going to look for a structure that's going to be at least 2 centimeters. That identifies ileocolic intussusception. Anything less than that will be small bowel intussusception. Find it first in the cross section. We'll identify these big circular loops, like a target sign. You can see the corresponding image on the CT scan. And then rotate the probe to get that structure into a long plane. You'll see the outer bowel wall and the inner bowel wall. Reminds me of kind of like a stack of pancakes. Here's the outer wall. Here's the inner wall. And then here, let's have a movie of a search for intussusception. On the bottom right side is what intussusception will look like. As the movie runs through, you identify that structure on the screen, and you can see that how doable and easy that is. So you got the right upper quadrant on the left side of the screen, and we're starting to see that structure pop right into view here. The most common spot to identify ileocolic intussusception is in the right upper quadrant. So although I described a complete survey of the entire ileocolic region and then progressing through the large bowel, I pay particular attention to the right upper quadrant. Easiest way to identify that is make sure you see your liver on the left top of the screen. Most children will have the gallbladder in view. And then right near there is right where the hepatic flexure is, and that's where you often see the ileocolic intussusception. So here's the image that we're going to identify. And when I'm looking for it, I like to have this image sort of blazoned in my mind to kind of remind me of what it is that I'm looking for. So I can gather this, but I like to think about some other food, perhaps, that will remind me of what intussusception looks like. First one that comes to mind is those big futomaki rolls. You know, you get like 5 pieces, and if you're sharing sushi, it makes it a little bit more difficult because who gets 2 pieces, who gets 3 pieces, makes for a difficult date situation. The other one I like to think about is a cinnamon roll because you can see the big swirl pattern. But I think the best example is turducken because you can see the turkey on the outside, and then you get the layer of stuffing, and then the duck and then another layer of stuffing and the chicken on the inside. Gives this swirl pattern. So here's another picture of intussusception using the curvilinear probe. You can see that it's nicely visualized with surrounding structures. The clarity is not as good because we have a lower frequency probe, but it gives you a brighter field of view. In the center we have the inner bowel, then the outer bowel wall, and then surrounding that's the anechoic area represents edema. An image like this makes me a little nervous. It says to me that that intussusception has probably been there for a little bit of time. We're starting to see some leakage of fluid. And it makes me wonder about the viability of that bowel. So the child's going to undergo reduction. I get concerned that there might be rupture as a result of putting that fluid in the bowel to cause the reduction. So I'd like to have my surgeon standing by and aware that this child is going to radiology. Once again, we can see that nice picture right there of the inner wall, the outer wall. So here's a nice picture of the intussusception. Some of the things that can identify, it's been called either the target sign, or if you have a brighter field of view and increase your depth a little bit, you may actually end up seeing, oops, sorry about that. You may actually see what's called the pseudo kidney or double kidney sign, because you can identify the intussusception right next to the liver, and then deep on the screen is going to be the kidney in cross section, and that'll give you that double appearance of sort of a double kidney or a pseudo kidney sign. Here's some other images of intussusception. Keep that in your mind. In the lower image, you can see a hypoechoic circle in the center of the intussusception. That's a lymph node right there. That might have acted as the nidus to cause the intussusception. Some other things that will be included on the differential that you can identify with ultrasound will be some mesenteric lymph nodes. They'll appear sort of as like edamame-shaped beans. Another one that'll give crampy intermittent abdominal pain, top left, will be gastroenteritis. We can see on this large bowel, this is actually transverse colon, with lots and lots of hyperechoic air pictured within the bowel, and those are outlining the bowel wall and the lumen. This is the one that can trip you up. Is on the bottom left, we're going to see some peristalsing bowel. It looks pretty close to intussusception, but you can see here, let me see if I can freeze this image right here, that these are real small, less than 2.5 centimeters for sure. And if you watch real close, the center kind of pulls right out of that bowel. And that shows that it's small bowel, which is doing its normal peristalsis, and the normal small bowel intussusception that we can identify. The things to consider when you're doing your study are what kind of other things might be confused with intussusception on ultrasound. One is the small bowel. So I remind you to stop and measure to see how big that is and see if it reduces on its own. If it does, then it's small bowel intussusception for sure. Second one is constipation. So you might see some clumps of hypoechoic stool, but it's not going to, it may shadow, and it may not necessarily be in the right upper quadrant. You will definitely not be able to lay it down into long plane to give that stack of pancakes appearance. The third one would be something like a thickened bowel wall, but once you get a nice view of it, you won't be confused because it won't have that target or double pseudo kidney sign. Thanks very much.
Now, if you want to hear more from Russ, look him up at ASAP. He's given a talk on endocrine and metabolic emergencies at the extremes of age. Sure to be an incredibly enlightening talk. Now, I know I told you that the peds ultrasound man, Andy Sloas, was going to be on here as well. We wanted to get his thoughts on this. Well, we got them, but they're too much to just tack on. So look for a bonus intussusception podcast coming right at you, right here, very soon. A little bit better place than we had earlier.
I can lift you up. I can show you what you want to see and take you where you want to be. You could be my
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Mike and Matt here, coming to you from Venice, the Ultrasound podcast. We're talking all the way across the world with Russ Horowitz over in Chicago, United States. Russ is there with Elvis Presley to talk to us about ultrasounding little kids and how not to make it weird.
Really? Really? Thanks, guys. Thanks.